Hello, everyone. My name is Tran Fabian, and I'm a third-year medical student at the Ohio State University College of Medicine in Columbus, Ohio. This project was a collaboration between Drs. Charles Elmiraghi and Tendy Chiang from the Otolaryngology Department at Nationwide Children's Hospital and Dr. Jennifer Mitzman from the Departments of Emergency Medicine at Nationwide Children's Hospital and the Ohio State University Wexner Medical Center. Today, I will discuss our investigation of the utility of plain radiographs for nasal fracture in pediatric patients. Nasal fracture is a common injury in children due to a variety of mechanisms. Consensus in the current literature is that plain X-rays have limited utility for diagnostic purposes of nasal fracture and states that obtaining them can incur unnecessary costs. Additionally, literature supports that due to anatomical accessibility, a nasal fracture diagnosis can be made with history and clinical exam alone. Essentially, this is a clinical diagnosis. Despite this, clinicians are still seeing patients with X-rays for nasal fracture. So even though evidence doesn't support its use, it appears to some physicians that it's still being done. And we notice that while X-rays don't have a use for diagnosis of nasal fracture, there has not been much reported on association between X-rays and surgical intervention or surgical decision-making. Therefore, a significant role for plain radiographic imaging in pediatric patients with nasal fracture has yet to be identified. Our hypothesis was that X-ray imaging for nasal fracture is not associated with referrals to ENT or plastic surgery, the recommendation to have surgery, or surgical intervention. Our questions regarding this topic included, what % of children who present to the emergency department or urgent care with suspected nasal fracture receive X-rays? And do X-rays influence the amount of referrals made to ENT or plastics and surgical intervention? Our study criteria included children ages 0 to 18 with nasal fracture who presented to the ED or urgent care affiliated with Nationwide Children's Hospital from 2013 to 2018. We excluded children who initially presented to a primary care provider, ENT or plastics directly, or basically any setting other than Nationwide Children's Hospital ED or urgent care. We also excluded patients who had CT imaging or any imaging for other suspected injuries, or who were transferred from an outside facility or institution. Regarding our methods, outcome variables included referral to ENT or plastics, recommendation for surgery, and whether surgical intervention was actually performed. Our predictor variables included age, sex, race and ethnicity, mechanism of injury, imaging type, fracture type, and imaging findings. This diagram is to help understand possibilities. For example, if a child had an X-ray done, the findings reported by radiology could be positive, where it was explicitly stated that a nasal fracture was present. It could be uncertain, where it was stated that nasal fracture was possible, or negative. After imaging, the child could have either been referred to ENT or plastics or not referred. Of those referred, surgery or no surgery were possible recommendations and outcomes. Similarly, of those who did not have X-ray done, they could be referred or not referred, and surgery or no surgery were possibilities. So among a cohort of 386 patients, our patient cohort had an average age of 13 years old, 70% were male, 67% were white, and 46% had a sports-related nasal fracture, which was the most common mechanism of injury. And from our cohort, 291 patients, or 75% of them, received X-rays. X-rays were more commonly performed in urgent care settings. No association was found between age, sex, race, ethnicity, health insurance, or mechanism of injury and X-rays. Additionally, type of imaging, meaning nasal versus facial X-ray, radiologic findings, positive, uncertain, or negative for nasal fracture, or nasal fracture type, defined as displaced, non-displaced, comminuted, were all not associated with referral, recommendation for surgery, or whether surgery occurred. Interestingly, among those referred to ENT or plastics, surgery was more likely to be recommended in the absence of X-rays with significance. However, referrals to ENT or plastics, or whether surgery was actually conducted, was not associated with X-ray imaging. So our findings that a higher likelihood of recommendation for surgery in those without plain films could be due to the fact that the trauma of the nasal fracture was obvious enough to warrant referral without need for decision-making aid of the X-ray. So essentially, with this finding, we may be capturing the more severe patients for whom it was clear they needed to see a specialist without the help of an X-ray, and who subsequently were recommended to have surgery due to that severity. This may even support the fact that nasal fracture is a clinical diagnosis, because the specialist still made a recommendation for surgery for some patients, despite not having an X-ray. Regarding our finding that more X-rays were obtained in the urgent care setting, this is possibly due to a lack of other imaging modalities, for example, CT. Essentially, we learned a lot from our study that X-rays are still being ordered for nasal fracture, and that a clear role for X-rays in children with nasal fracture has yet to be defined. Reducing X-rays ordered in children with nasal fracture could also reduce radiation exposure to children, in addition to costs. Future directions include finding out who is ordering the X-rays, more education from parents, and that could be through the means of a Healthy Children's article, or looking at patients with nasal injury diagnosis codes in addition to specified nasal fracture. Thank you very much for listening. These are my references, and please feel free to email me questions.